So I'll just start with a question for Ben, just because we haven't gone through some of those from earlier. But quite a few people have actually really been asking about Awaken, actually, and who would be able to join the training program, what that would look like. And someone asked a very specific question, I think, about whether a level 4 counselling, where has it gone? A level 4 diploma in counselling would be enough. So very specific there, but I think more broadly that could be helpful.
Okay, so the thing about the training of psychedelic therapists, it's a really important thing. Psychedelic therapy is a specialist form of psychotherapy. You've got to think that. What we can't do with specialist psychedelic therapy training is turn a non-clinician into a clinician. No matter how much interest you've got in psychedelics, the amount of people who contact me and they go, hey man, I want to be a psychedelic therapist. And I'm like, why? And they go, because I love taking LSD. You know, that's not going to be good enough, you know? So you have to be a registered clinician. Now, you can be a doctor, a psychiatrist, GP, you could be a nurse, you could be a social worker, you could be an occupational therapist, or even a physiotherapist, you could be a counselor, you could be a psychotherapist, you can be a clinical psychologist. You need to be a clinician working under regulated, supervised practice as a clinician. Then you do psychedelic therapy training on top of that as a specialism. You can't just, no matter how much personal experience you've got with psychedelics, even if you've been a wonderful underground therapist, and trust me, I know there are many who've been working with plant medicines for 30 years. If you're not a registered clinician, you can't do a 3-week training in psychedelic therapy and start seeing vulnerable patients in an unsupervised, unscrutinized way, at least not with our training scheme. You can work underground, as people do, which is fine if that's what patients are happy to do. But we have to be really strict about that psychedelic therapy is for people who are already clinicians. Now, what we're going to be doing though at Awaken is we've got 2 different forms of training, because we've got these online modules, like 10 or 12 modules on all aspects of psilocybin, DMT, LSD, MDMA and ketamine. And anyone can do those. Those are open to anyone, and you can collect CPD points or CME points by doing these, and they can be for anyone. But if you want to do the face-to-face 10-day training course, that is only going to be for clinicians.
Okay, thank you. I think that's probably cleared up a lot of people's questions. And Meg, there was a question for you, just actually on one of the last things you mentioned about the neural mechanisms for psilocybin in anorexia nervosa, and just whether you had any thoughts or what you hypothesized the outcome of that was going to be.
Ooh, yeah, that's an interesting question, and I don't know that I have a really clear-cut answer just yet. So we're talking the MRI and EEG stuff, yeah? Yeah, so one of the things I'm really interested in is how we can measure neuroplasticity. And obviously that has applications here in psychedelics. Is, you know, it's one of the mechanisms that we think psychedelics work through, you know, is that increase in plasticity. So one of the things I've been working with my team here and my team in Auckland on is developing sort of particularly EEG indices of neuroplasticity. So what I would like to see is whether we can index those changes, whether we can measure the changes in neuroplasticity that might be occurring, that might underlie the therapeutic effects. So that's one thing that I'm interested in. In terms of the MRI, I don't know. I'd have to really give that a bit of a thought, because it is, you know, no one's done this before in anorexia, and we've got some interesting sorts of paradigms that we're going to be doing in our MRI. So I might just have to say, watch this space on that one.
Well, thank you. I mean, it's amazing because, you know, I think we are going to learn just so much from what you're doing. It's really groundbreaking stuff. And Ben, there was quite a big question for you about sort of around Awaken again, but I guess this is something that's coming up more and more as psychedelics become more and more mainstream. But it was how to Awaken increase accessibility for marginalized communities who would really benefit from psychedelic assisted therapy, considering the social determinants of trauma and so on.
Yeah, I love this question because I answered it in the Q&A.
Oh, great.
A lot of people, there's some criticism, you know, this is private healthcare, this is going to cost people, and indeed it is. it's going to cost money to run these programs and open these clinics and pay the therapists and pay for the medicines and do the therapy. It has a price tag on it. Now, there's nothing, I'm a socialist and a firm believer in the NHS. There's nothing I want more than psychedelic therapies to be free on public healthcare, approved by NICE and the MHRA and paid for by the NHS. That is the goal, absolutely. In some ways, that's not really my fight. I will do what I can to encourage that by producing safety and efficacy data and lobbying the government. I've been doing it for 15 years. Myself and David have been lobbying the government, successive Home Secretaries, to do this. The NHS is a very slow and archaic and cumbersome organization in when it decides to fund things or not. What I'm not going to do is not open the clinics just because the NHS haven't caught up yet. We need to open these clinics, get the platform out there so it at least exists as a thing. And in the meantime, someone's got to pay. I don't care who pays. I don't care if it's a rich patient, a CCG, a GP, AXA, Bupa, Wellcome, the NHS, and NICE. I don't care who pays, but someone's got to pay for this treatment. And yeah, at the beginning, it's going to be a rich patient, and that's just all we can do. Because what's the alternative? It might be 10 or 15 years before the NHS pulls its finger out and decides to start paying. So I will do what I can to support that and expedite that. But in the meantime, it's just going to have to be paid for out of patients' pockets. And sadly, that does exclude people who can't afford to pay for private medicine, which is most people. So I don't know a way around this, but the health economic argument for psychedelics is very strong, and we need to be lobbying governments for this.
Yeah, well, I mean, I think that says everything, really. Oh, sorry, Meg.
No, I was just going to add something and say, I think Ben's right that it's, you know, at the beginning it has to come from people's pockets, but at the same time we can be looking at ways that we can provide other means where people who might be less have less resources might access still support. So things like integration, those kinds of things are kind of popping up that can help if people can't afford the therapy just yet. But it's all moving in that direction of helping to increase across the board, right? Increase access rather across the board.
Yeah, exactly, definitely. And I think it's paving the way, isn't it?
If you look at the funding, like there's nothing more expensive in this world than untreated psychiatric patients. They cost a bomb. The untreated heroin addict, the untreated alcoholic, they go in and out of hospital, they go in and out of prison, they have their legs cut off, they get lung disease, they get liver disease, they get HIV, they have their children taken away by social services, they have very expensive psychiatric inpatient admissions, they cost millions to the public, right? So the upfront costs of psychedelic therapy seems a lot. It might be, we don't know what it's going to be. Could be 10 or 15,000 pounds for a 12-week course of MDMA therapy. Sounds like a lot of money, but if that cures a patient of PTSD or alcoholism and we never have to see them again, you have saved an enormous amount. So psychiatry has had this perennial problem, you know, it's so cheap. You know, what's a course of Prozac? It's like £2.80 a month for a course of Prozac. It's nothing. So the result is we just give these people these maintenance drugs and we never treat them properly. We need to put money in up front in a prophylactic way to get people out of our service so they don't have to darken our doors the rest of their lives. But this is a perennial problem about getting decent funding for good psychiatric care. Psychedelics are a really good example of that. It's expensive to run psychedelic therapies. This is a lot of staff time involved, but it makes long-term economic sense. But this is a political thing. It's not really a therapeutic thing.
No, definitely. And I think that's true. I sometimes get asked, people, I'm very into preventative medicine and sort of public health and things. And people say, well, why don't we do these exercise schemes or whatever it is, a sensible preventative thing to stop the crisis happening? And I'm like, I don't know, it would work out much cheaper for everyone in the long run. So
there has been a really good study done recently. I saw a presentation on it, I can't remember where, last month. Someone did a really excellent economic analysis of the costs of psychedelic therapies for all different compounds and how they are fairly expensive compared to just giving someone Prozac, but how over a lifetime you save billions. So there's a strong argument for it.
Yeah, and I think as well, what I'd just like to sort of raise what drug science and SSDP are doing in sort of spreading education, getting education out there, getting people knowledgeable about these medicines and what they can do. And I think that that's also the first step in increasing access, is increasing our knowledge base.
Exactly, definitely, and shifting public opinion and all of that good stuff.
Exactly.
So Meg, there was also another question for you about why psilocybin is picked for your study, and also about the sort of what possibly the interaction is maybe with the control aspect that comes into eating disorders.
Oh yeah, so that's another really good question, and it is a something that comes up quite a lot, is the sort of the control aspect in anorexia, and it is true that control does play a big part, but I think we also need to ask the question of control of what are you controlling, and I think that sort of, if we can get at the root of that question, then that might be quite informative. So, and I think that there's a similarity across other mental health conditions. So if you look at any like addiction, what are you trying to control with your addiction? I think it's more obvious with eating disorders because there's this idea of anorexia being people with high self-control, and addictions being the opposite. But I don't know, maybe there's something similar underlying that control in all of these conditions. And I asked the question, control what?
I think that's really, really interesting. If you listen to a great podcast on The Guardian, if anyone wants to, on this issue, highly recommend. And then I think then we'll do one last question, and then we will stop for our comfort break before our fantastic Zendo and Psycare session that's coming up at 5 o'clock. So I think maybe this is just quite, actually perhaps you could both answer this, but just regarding psychedelic assisted therapy, how easy is it to predict how well someone will respond to it, and can you predict that?
Do you want to go first, Meg?
Can you predict how well someone will, or how someone will respond to
how someone will respond, I suppose, and whether how likely it is to be successful?
There's a lot of work going on in the space for identifying predictors. I think having good preparation is key, and having preparation with people who know the space, having a good therapist who can guide you through that preparation is key. And I mean, in my eyes, that's the biggest difference between what will be a good and a bad outcome, is how prepared someone is to go into it. And I'll then take over here because I'm sure he'll have much more to say on this.
Okay, so that's a really good question. It's my favorite question of all the ones that we've seen today. Firstly, we just don't know enough. This whole field is in its infancy. We're just in the embryological stages of this. Imagine where we're going to be in 5, 10, 15 years. Imagine where we're going to be with genetic carrier typing about responsive to drugs. Will it come the day when the first thing you do when you go into a psychedelic clinic is to give a sweat sample and your genome is analyzed and a perfect bespoke pharmacological compound is provided for you that fits you perfectly? I'm sure that's happening across all parts of medicine, especially psychedelics. In the meantime, we can look at different personality types. There's been some good work at Johns Hopkins around personality types and psychedelics and predictions. I don't think there's going to be I think there's going to be a very wide spectrum. It's about management of trauma. You could ask the same question. How do different personality types respond to trauma as a child? And the answer is, well, personality is formed by trauma as a child and your experiences of attachment. So we have to be flexible to manage all personality types and flexible to manage all people. So I don't think it's going to exclude anyone, but there's a lot more work to be done in terms of who's going to respond to what drugs. We're at that stage where we're hitting things with a very blunt hammer. That's why we did the alcohol study. We wanted to broaden beyond PTSD. One of the things I've been saying quite a lot recently is, in my opinion, any psychiatric disorder that responds to psychotherapy will respond better to psychedelic assisted psychotherapy. And that's all. That's everything from eating disorders to personality disorders to schizophrenia to depression, affective disorders, bipolar disorder, you name it, all addictions. They all use psychotherapy, all of these things. If they use psychotherapy, they're going to be able to use psychedelic assisted psychotherapy. And the other thing is that I think there's greater similarities between psilocybin, ketamine and MDMA than there are differences. Obviously, I understand there are different subjective psychological experiences with those different compounds, but the concept of sitting in a room with a therapist whom you trust, that you can engage with, and using the altered state of consciousness to access parts of the psyche that normally you would repress and avoid, that's common to all the psychedelics, whether it's MDMA, ketamine, or psilocybin. So I think we've got to not allow ourselves to pigeonhole things, you know, and psilocybin for depression and anxiety disorders, MDMA for trauma. We can really broaden it. And I think in the next 5, 10, 15 years, we're going to see a big broadening of different psychiatric conditions and well people, just to mention one of the other questions. You know, one of the things Albert said just before he died in 2008 was, he said, when the psychedelic renaissance occurs, the doctors must not be allowed to run the show. I totally agree with that. You know, it's that, I mean, my whole life's work has been around working with clinical patients, but these are superb, interesting compounds that people who are not in the clinical population can use for personal self-development, families, children, communities. You know, they should not be restricted only to research protocols or clinical populations. And I long for the day when we have psychedelic centers on every street corner, not just for patients, but for people who wish to improve their well-being. They're very safe, much, much safer than the pub on every corner.
Yeah, and just to add one more thing to what you just said, Ben, I think it's important that even though it is obviously informative to know who might respond better to what, we do want these medicines to be available to everyone, and you don't want to create an environment where people are going, oh, well, you can't have it because you're this personality type, and you can't have it because you're this personality type. It's more about kind of adapting the way we approach medicine so that it's available for everyone.
Yeah, absolutely. I think that is a fantastic point to end on.